Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware, each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the chat pod located to the right of your webinar platform. You may also download a copy of today's presentation using the Files pod located directly below the presentation. It is now my pleasure to turn the conference over to today's first presenter, Chris Hunt. Please go ahead.
Thank you. Hi, everybody. Happy New Year. Welcome to 2020 and our first AHA team training webinar of the year. This is Shrinking the Change and Leveraging Bright Spots in Your TeamSTEPPS implementation. And this is Chris Hund. I direct the AHA team training program, and I'm a Senior Director of the Center for Health Innovation at the American Hospital Association in Chicago. So thanks all for joining. All right, just some rules of engagement. As normal, audio for the webinar can be accessed in two different ways. If you are listening to it through the phone, you're going to want to mute your computer speakers, because otherwise you get weird feedback, like if you call into a radio station. And you could also listen through your computer. Sometimes people have internet connection issues, and so that's why we recommend listening through the phone. There'll be a Q&A session at the end of the presentation, but what we'd love for you to do is to chat your questions into the chat pod that you see on your screen right now. That's a great thing for you to do, because what we'll do throughout is try to answer your questions. There's a team here ready to answer questions as we go, and if it's something that we feel would benefit from a larger discussion, we'll save the question for the end of the presentation and have a discussion that way. So please just chat questions as we go throughout. So something new this year in 2020 is that we are offering continuing education credit for attending these webinars. So that's new this year to be offering that. There's some instructions that you need to do, though, to get this continuing education credit. So first thing is that you need to create an account with Duke OneLink. Duke University is who offers our continuing education credits, so you need to set up an account with them. Instructions can be found for this in the file pod, which is on your screen right now. You could download the instructions that say Instructions for CE Credit. If you have any questions about this, feel free to email us at teamtraining@aha.org. You must use a mobile, you must update your mobile number with this Duke system, because that's how we actually go about and give you your credit. So within 24 hours of watching this webinar, you text the number that's on your screen. It should also be in the instructions with the SMS code CAYSUR. And that's all you need to do to get your CE credit. You need to do this within 24 hours of the webinar, and then you'll receive your credit. So we can only offer it to people who are watching this live, but just something new this year, something that we're trying to give a little bit more value to what we do with the AHA team training webinar. So hopefully everybody can take advantage of this and use it. The CE credit is good for all kinds of professions. It's good for CME, for nursing, for pharmacy, for other kinds of allied health professions. So hopefully it's something useful for everybody. Some upcoming team training events. Our first courses, master training courses of the year, are filling up already. So whether you're new to TeamSTEPPS or looking for some assistance because you're already far in your journey, we have a course for you. So we have master training courses, which go through all the tools of TeamSTEPPS, help you understand how to manage change, how to implement, how to measure. This is really the traditional TeamSTEPPS course you've heard of. We're now offering fundamentals courses. This is just really the tools, so it's good if you feel like you need a refresher. It's good also if you feel like there's some people in your organization that maybe you want to send through to be champions of this, but they don't need to understand how to manage the change, how to implement, They just need to kind of have a basis in this. And the other kind of course we offer is the TeamSTEPPS Next Steps workshop. And what this is for people who have already implemented TeamSTEPPS, are already on their journey, and they think to themselves, I'd really like to amplify this. Like, this is going well. I want to spread this farther. Or they think to themselves, God, we're having some challenges here. I really think I need some help. That's what this is for. A lot of people have both. They're having a lot of successes and some challenges. So that's what this Next Steps course is for. So consider coming to those. Our conference is in New Orleans this year, June 3rd through 5th. Early bird registration is now open. This is a conference that's about way more than TeamSTEPPS. It's about really anything that has to do with improving your healthcare environment through the use of teamwork. So it's wide-ranging topics. There's a really diverse group of people who applied this year to be presenters, so thanks to all those people. Special thanks to those folks that have been accepted to present. We had a great number of applicants this year, so just thank you to everybody. It should be a great event. And then next month, our webinar is on February 19th from noon to 1 Eastern Time, and that is on measuring teamwork culture using the TeamSTEPPS Teamwork Perceptions Questionnaire. So I know a lot of people really enjoy those measurement topics, so we're bringing one of those back. Contact information, as always, you can get in touch with us online or through our email address or the phone number there. We strive to get back to you as quick as possible with to answer any questions you have about the program or technical questions about how to use TeamSTEPPS or other tools. So please get in touch with us. Don't hesitate to do that. All right, enough from me. I'm going to toss things over to today's presenters. I'd like to introduce them for you. There are three individuals that have really become synonymous with team training and with improving teamwork really across the country. I know a lot of you have had interactions with them in some way or the other. They've been presenters at the national conference, here on our webinars, and are some of our traveling faculty that go around and do a lot of work around the country. So today we have with us the Clinical Director of Team Performance at UW Medicine, University of Washington Health System, and that's Ross Ermentrout. We also have Megan Sherman, who is the Associate Director of WISH, and WISH is the WWAMI Institute for Simulation and Healthcare, and I'll let Megan, when she talks, tell you exactly what WWAMI stands for, but I believe it's Washington, Wyoming, Alaska, Montana, and Idaho. And then also we have the other Associate Director of WISH, Farah Leland. So, like I said, all three of them have been instrumental in growing the team training movement in this country, and so I'm very happy to have them here today and to have them provide us with what I know will be a great presentation. So I'll turn it over to you guys now.
Thanks, Chris, for that wonderful introduction. My name's Farah, and I'm going to go ahead and get us started. So just to talk a little bit about where we come from so you can kind of get an idea of our experiences that Ross and Megan will talk about a little bit. We're from University of Washington Medicine, or UW Medicine as we call it, and that includes 4 hospital systems, over 200 clinics, and some affiliates as well. So pretty big system. Part of our community includes over 2,400 faculty members and 30 departments, 4,700 clinical faculty across the WWAMI region, and I am proud to say that Chris is exactly right on what WWAMI stands for: Washington, Wyoming, Alaska, Montana, and Idaho. 4,500 students and trainees, and over 27,000 employees in our system. So for today's webinar, we're going to talk about 3 main topics or objectives, and that's around identifying the bright spots in implementation process and how to leverage them, and Ross is going to talk quite a bit about that and how we like to think about that. Objective 2 is to understand the need to evaluate the process frequently and really just make adjustments and evolve your plan. We use a 30, 60, 90-day approach, and we're going to give you a template that we use as well. And I think it's one of the files down there. And then objective 3 is to really understand the difference between ownership and buy-in, and really why we think ownership is essential in implementation and moving towards ownership instead of buy-in. At UW Medicine, when we work with a team or a unit, we start by forming a change team, and that change team is interprofessional. We always want to include frontline and leadership members, both equally important. We want to provide the ownership versus buy-in, really giving them the change team the ownership perspective. They meet monthly, and they really are those drivers. They design the implementation, and we act more as the consultants to kind of give them tips and tricks along the way. They lead the trainings with some support from us, and then they serve as ambassadors within their units and throughout our system as well. So the ownership versus buy-in, there's an article by Henry Lipmanowitz from Liberating Structures. You can find this article. It's an article that all our change team reads, as well as any group that we work with. If you've taken a course from us, we've given you this article. Basically, what we're trying to move towards is really looking at ownership as opposed to buy-in, and this article really does a great job of outlining why that's important and how you might do that. So when we talk about resistance and implementation, we're really going to focus on ownership and why and how to get there. So really, TeamSTEPPS is happening, but you get to decide how it happens. So we're going to do it, but you really get to decide how it's going to work within your unit, within your group, or your team. The change team designs the implementation. It's really not a top-down approach because you have those frontline staff on your change team who are giving input and owning the process.
And hello, everyone. This is Ross. And just to follow up on that, yeah, a big part of what we do is push back really hard on the leadership, saying that the frontline staff have to own the process. You still have to have the leadership on the change team because they have to make a lot of those logistical decisions for training, etc. Now, if you've been to a master trainer course outside of what we teach, you've probably heard a lot about the John Cotter 8 Steps of Change, which is the TeamSTEPPS curriculum. We use that, but we also focus on the switch model of change. And what you see up here are the 3 components of the switch model. It's by Dan and Chip Heath: direct the rider, motivate the elephant, and shape the path. And we're not going to focus on that whole model today. What we're going to do is bring out some points from those that are highlighted in red there. And as we go through this PowerPoint and this webinar, it'll make more sense to you. So the goal here is to really focus in on that ownership part of the implementation plan. One of the things we do right up front, and this also comes from the switch model, is develop a destination postcard. Those change teams that Farah talked about, we have them sit down and develop a problem statement, and often that involves doing the team perception questionnaire, which is part of the TeamSTEPPS curriculum, with that department or that division or whatever group we're working with, and have them develop a problem statement, and then from that problem statement develop a destination postcard. And I show this specific one a lot because this has been a huge success for us over the last 3 years. As one of our operating rooms in our system decided they wanted to implement a morning brief in every OR to plan for the entire day in each room. That was their destination postcard. Their problem statement was there's a common disconnect in developing a shared mental model for all cases throughout the day. And basically what they do now at 7 a.m., the surgeon, the circulator, the surgical tech, and the anesthesiologist or CRNA, they meet at 7 and discuss that room for the whole day. It's been a huge success. But they started with this and communicated this to everybody in the OR. There's 27 ORs at Harborview, so it's a huge staff, huge amount of surgeons, huge amount of providers. And so they communicated earlier and started addressing resistance early on. And with that, we're going to talk about some resistance, or Megan is.
Yeah.
Hi everyone, this is Megan. So as Ross mentioned, kind of starting out with your destination postcard, this is identifying your end goal, your end game, what it is that we're trying to achieve. And oftentimes what we experience is kind of the next step as change teams or implementation individuals are getting started in this process. The next step after setting your goal is thinking about resistance. How do we overcome resistance? Because we know as human beings it's kind of part of the deal. There's going to be some hesitation to make changes in our day-to-day lives. So just want to maybe ask the group to chime in the chat box. Think about why do you think, what are some of the underlying reasons or reasons that we resist change as humans? Let people type in. Fear, a lot of fear, fear of the unknown. Okay, we have a trend here. More work. It can be disruptive. There's not enough time to do the change or make the change possible. People feeling that they're losing their control, that it's different from the status quo. They like keeping that status quo. It's different. It's asking them to go outside their comfort zone or comfort level. Stress. These are all great examples, and so I think we've touched on most of these, but a lot of the reason why human beings resist change, it can be related to some of this. Fear, distrust, lack of communication about the process or what it is that we're trying to achieve. People may think that it's just a fad or a flavor of the month. If I can wait it out, it's not going to affect me, or I can kind of keep doing what I'm doing. Others, maybe that it challenges our routine. Again, getting back to that comfort zone. Initiative fatigue, this is a big one, especially in healthcare, is that we are asked to do so much that we may, it may be overwhelming to consider adding something else to our plate. And then lack of understanding, and this is probably maybe one of the biggest ones, is having an ability to overcome resistance is by being able to better communicate the why, getting people to build that ownership or that feeling of why is this important, why am I doing what I'm doing. So thank you for participating in that. I want to point out before, we're going to talk about some of those in more detail, but first I want to show this table. This was something that was shared with us a few years back, and it's available in your downloadable slides. This is a resistance audit, and one of the things that we see as individuals that may be experiencing resistance, either as a change team member or someone who's leading this implementation, is that some of this resistance may be tied to kind of deeper misunderstanding of what's actually going on. And so thinking about how resistance manifests itself in these observable behaviors, using that to kind of get to the underlying reason of what it is that's behind this resistance. So for example, someone on the team that may just be perceived as having a poor attitude, and that's manifesting itself in delays and excuses, not starting or not being engaged in the implementation or the rollout of this. It really may be tied to a deeper confusion of what is their role in the process. How are they fitting it in with their other priorities, or what else they're being asked to do? And so thinking about tying this back to how do we get to that period or place of ownership, really allowing opportunities to talk through some of that, providing explicit instructions, talk through some of that confusion, and maybe proactively or more frequently check in with individuals and see, are you understanding where this fits in with our priorities? So I'm not going to go too much into detail for the rest of these, but again, just thinking about as we overcome resistance, looking at what are the underlying causes. So as I mentioned, we're going to dive into a couple of these in a little bit deeper. So thinking about fear, fear is one of the kind of knee-jerk reactions that I think a lot of us have to change when it's presented. And really it's fear of the unknown. We saw that in a lot of comments on the chat box. Fear of the unknown, fear of what's coming next, how is this going to impact me? And so thinking about how you can tie this back to ownership, resolving fear through opportunities for people to share their concerns or share that, communicate kind of what's going on in their minds, and being able to address those or anticipate those as a change team or as someone who's implementing this change. Additionally, lack of communication, if kind of left unchecked, people may feel that they have they don't have enough information, so they're filling in the gaps themselves. This can lead to rumors or anxiety because people don't know what's going on. So thinking about how to message things, and oftentimes the message can be lost just because I've sent out communication, or at least my perception is that I've sent out effective communication around this initiative and what we're doing. It may be an email with a PowerPoint attached. It doesn't necessarily mean that that email or that communication was received by everybody on the team. Or even if it was received, it may not have been digested in a way that makes sense to them. So thinking about how to structure your communication in a way that comes in multiple formats, in multiple ways, and throughout. It's not just a one and done. It's kind of an ongoing process of communication to, again, kind of check in throughout and make adjustments to people's concerns or individual issues that may arise during that. It's also very important, and I know it's our last bullet on this slide, but it's very important to consider listening too. Communication is a bi-directional thing. Just because you're sending out the information, you also, as effective implementers, need to take the opportunity or take the time to listen to the feedback of others. And this, again, tying it back to ownership, really provide people, once they see that that information is really being heard and adjustments are being made, it's much easier for them to continue to feel like they have a role in this process. Another one that we see a lot, and I mentioned especially in healthcare, is this kind of the fact that it's a fad or a flavor of the month, or it's just initiative fatigue. Like I said, we have so much going on, all of us, that it's sometimes hard for us to be able to prioritize. Where does this fit into what I'm doing on a day-to-day basis? How can I make this this actually happen with everything else? And so what we, with some of the groups that we've worked with, we've talked about communicating team steps in a way that it's not another initiative. It's not meant to be an add-on. It's meant to be built into what it is that we are already doing to make the process of what we're doing easier, more effective, more efficient. And as people start to see that those successes, those kind of short wins, and Ross will talk about bright spots, as we're starting to build on that, it's a little bit easier for people to, it's more manageable in a sense. And so thinking about how do we emphasize that in our communications and our messaging, that, again, this is not just another thing to add to your plate. And finally, and I want to say this is probably the biggest one, and it encompasses some of the other feelings relating to resistance, this is overall lack of understanding. This may be lack of understanding about what needs to happen in some of the logistics, but more often it's the underlying why. Why is this important? What's in it for me? Why should I be paying attention to this, and why should I be doing this? And so thinking about, again, getting back to that communication, what's conveyed in the message? Are we appealing to that underlying why this is needed, why this is a benefit to patient safety? And by setting that stage, ultimately, we give people the opportunity to step into the process and really own it, getting back to that ownership. By providing that information, by providing why that change is necessary, and allowing people to help modify the messaging over time. So whether that's engaging frontline staff members in the success stories, why this has made a change or how this has made a change, building on those bright spots that Ross is going to talk about.
All right, thanks, Megan. So, yeah, let's get into a little bit of discussion on some of these areas. And you know, the reason we spent that much time on resistance is you know, human nature is for us to try to avoid that resistance and go right to the bright spots and stuff. But we can't avoid it, and we have to address the resistors. But there's different ways we can do it, and one of it is to address the bright spots. And you think about, we can always come up with reasons why something will not work. But if you kind of reword that into a way, yeah, you're right, it might not work, but if it did work, would it be valuable? And that's what we really spend a lot of our energy on. So let's think about that a little bit. What I've got up here is, what's working and how do we build off of that. And again, if you're familiar with the switch model, you'll know that they talk a little bit about Jerry Sternin, who is kind of the guru for positive deviance. And basically positive deviance is looking at those things that are not normal behavior, but you're getting positive outcomes from them. And a while back, well, 20 years ago, 30 years ago now, he was asked to go to Vietnam to help out with some malnutrition in Vietnam. The malnutrition rate for kids under 5 was like 75% in Vietnam. But it was an organization that asked him, and the government didn't really want him there, and they said, you can come, but you're only staying for 6 months. And all of Jerry's friends said, well, you can't do anything in 6 months. There's a huge uneducated population there. There's a huge poverty problem in Vietnam. In 6 months, you're not going to make any difference. And Jerry Sternin calls that TBU, true but useless information. And that's very true. He's not going to be able to change poverty in 6 months or an education issue in 6 months. And we hear that a lot. And I would have said it too. When I was working at the bedside, I probably would have said things like that too. I got up here a couple examples. One is that interprofessional rounding. And I know when we first started looking at that, we heard things, interprofessional rounding being in the acute care. So the ICUs have been doing interprofessional rounding, been doing it well for a long time. In the acute care settings, it's a little less common and a little harder to pull off because that frontline nurse might have 3 or 4 patients, and those patients might be on 2 or 3 different services. And so we heard that early on. Well, I have 4 patients. I have to pass my medications at 9 a.m. 2 teams round at the same time. And that's true, but it's also useless information. We are not going to change that information. But then the next thing is you say, but if you could round with the team when they're seeing your patient, would it provide value? And 100% of the times the nurses would say, yeah, absolutely, it would provide value. Because then I don't have to go to my patient after rounds and say, hey, what did the team decide your plan is for the day? And those of us that are nurses have been there and seen that happen. So they worked, and at the time the national average is around 7 or 8%. And that it was interprofessional rounding, which included nursing, pharmacy, social worker in some areas, and obviously the providers. And they quickly went from 7% up to 75%. They found the value, and then they said, okay, how is it working now, and how do we build from that? And we'll spend a little bit more time on that in a minute. But anyway, Jerry went over to Vietnam, took his wife, took his son, met with some people in a village, and said, how are you guys feeding your kids in this village? And most of them were malnourished, and everybody was doing the same thing. The adults and the kids were eating bowls of rice, a bowl of rice in the morning, a bowl of rice in the afternoon. And then he asked the group, is there anybody whose kids are not malnourished in this village? And it turned out there were 2 families that weren't. And he said, well, what are they doing? And nobody really knew. So they went and talked to those 2 families. It turned out all they were doing is taking that same 2 bowls of rice and putting it in smaller portions and giving it to the kids in 4 meals per day. Exact same amount of rice, just splitting it up into 4 meals, and then going out to the rice paddies, getting some crabs and tiny shrimp and grinding them up, throwing them in the rice, giving some protein in it. And those things were considered unacceptable food for kids for no apparent reason. But they were doing it. Well, Jerry went back to the original group and said, here's the bright spot, here's what they're doing. Are you guys willing to try that? And the rest of the village said, yeah, we'll try that as well. And what happened, long story short, is Vietnam let Jerry stay longer. He took people from that original village to other villages to teach the other villages to do the same thing, and the malnutrition rate went from greater than 70% to less than 30% for kids under 5, and it didn't cost anybody a dime. He found what was working on those groups, on those smaller areas, and was able to extend that to the larger group. So we found that with the interprofessional rounding. They found value in it. They found that, yeah, is it going to work 100% of the time? No, but let's figure out how we can make it work most of the time. And that's what they did. And I can tell you, when we went back the first few meetings and followed up and looked at the reports, early on, you would hear things like, well, yeah, it's working most of the time, but not all the time. What are we going to? They wanted to focus on why it didn't work versus how it worked and how we built on that. And in fact, one time they said, well, we had a patient code right during rounds. Well, you can't control that. So you focus on what's working. SBAR report, one of our areas developed a tool, a template to do an SBAR report. It's an interprofessional report, attendings, nurses, social work, and mental health specialists, one of our psychiatric units. And they started off early on getting some success and then kept building from that. What's working? How do we make this better? And that was 4 years ago they started doing that, and at this point they have almost 100% compliance. The attending physician actually gives the report, and there's just one attending physician that refuses to do it. Goes back to Megan's resistance on the bottom of that chart that she showed you to begin with. There's just certain people that aren't going to change because of the change. Don't spend your energy on those people. It goes back to, you know, the philosophy and leadership. We spend 95% of our time on 5% of the people. Well, let's take those people that are already wanting to do the change and focus on them and work on the people that are on the fence. And that's what we spend a lot of time doing on our TeamSTEPPS is, okay, we've got this group that wants to do it. We've got this group that's not sure. We want to pull those to that side and eventually get everybody else on board. One of a great examples in our ambulatory setting is that last SBAR telephone encounter. One of our clinics we worked with, a huge clinic, multi-specialty clinic, they decided early on they wanted to kind of clean up their telephone encounters and spent some time with them, went through some SBAR simulations, which is basically we put what I like to call word vomit up on a projector, and then the groups just practice on putting it into a SBAR format. And they were doing really well, and after about 4 or 5 months, they called us back and said, hey, can you guys come back and work with us? There's still some people struggling with it. And we said, sure, we'll come back, but are there people doing it well? And they said, yeah, there's quite a few people doing it well. Okay, well, let's have them share with the team what's going well versus 3 people they hardly know coming in and doing it. So built off that. From that, it worked over to the front desk staff. So they're not even clinical people doing SBAR communication. Something's going on in the waiting room. They need to communicate to the MA or the RN or the provider, whoever it is. They also do that in SBAR format. So this is not just strictly the clinical staff that you're thinking about. So as we go into, and I was looking at when people were responding to Megan's question about why do we resist, and there was a lot. One of my favorite ones was, others need to change, not me. And, you know, we all said that, right? Well, if everybody else would just change, this would be a better world. But it doesn't really work that way. So one of the things you have to do is you have to tap in to what's in it for me. And Megan mentioned that. And we work with Pete Napolitano, who's an OB doc, that he calls it WIFM radio, what's in it for me. And so everybody wants to know what's in it for me. We know that TeamSTEPPS is the right thing to do, but people still want to know a little bit more. And everyone is different. You can't use the same thing for the CFO as you're going to use for that frontline nurse. I can tell you a big thing that we hear when we go in to work with groups is we need to increase throughput. We need to increase throughput through the emergency room, which is great, you do. But what that means to a frontline staff versus what that means to administration is 2 different things. And so you have to tap in. The frontline staff sees that you want me to do more work in less time, right? Not everybody, but a lot of them do. So you have to change that around. And you say, well, what's this mean to you? And I can tell you, in one of our hospitals, if patients don't get seen in our emergency department, you know, we take the indigent and the homeless, and they don't get seen anywhere. They don't have insurance, and they don't get to be seen anywhere. That's what motivates that frontline staff is, I'm working here because I want to take care and make sure those people get the care they need. So you're still increasing throughput, you're just not calling it that. So a little bit of reframing on it. And one of my favorite quotes I heard from somebody once is, it shouldn't be, to go back to the ownership versus top-down thing, I shouldn't be going in and saying, how can I get this group of people to do what I want them to do? The question should be, how can I get this group of people to do what they want to do? And that's where you really get that ownership versus buy-in. And I know if you were on the webinar last month, Kurt O'Brien talked about ownership and buy-in too. We live and die by this in our system. And so how can I get this group of people to do what they want to do? We guide them when we're talking about TeamSTEPPS implementation. We use the Team Perception Questionnaire Survey. We come back to that. Same thing with that, the Harborview OR when they did the morning briefs. What was in it for the surgeon? What was in it for the circulator? What was in it for the anesthesiologist? They all want to know. And as they sat down and they said, this is what we want this to look like versus their leadership saying, we want you to do this, that's where they got the success. And they've had huge success. In fact, it's really starting to go throughout our system now. And so when we work with people, we talk about shrinking the change. And again, this comes from the switch model and scripting those critical moves. Now, I know we looked through the questions that came from when some people registered for this webinar. They sent some questions. And I know that there's areas out there that have trouble putting together change teams just because of the size of the hospital, like critical access hospitals, I know struggle with that. And that's okay. You don't have to have a change team in a big organization like ours. It's important that they do because then those people get to design the process. But as Megan talked about in the resistance, integrate TeamSTEPPS into what you're already doing. So if you already have a group meeting for something else, whether it's Epic or whatever it is, you think about how do we get this in there, and then how do we give them clear instructions, or how do they come up with a clear plan that doesn't overwhelm anybody? When I first went to my master trainer course and came back, I was the patient safety officer at Harborview Medical Center, which is one of our hospitals here at the time, and I was so excited. I thought, I am going to implement TeamSTEPPS everywhere in our system, and I'm going to do it all at once, and I'm going to pull out the 20-plus tools, and I ended up going to a group that didn't have the same plan I did, and it was a colossal failure. And so from what we came out of that for us is to look at, okay, let's shrink this down a little bit. Let's not overwhelm people. Let's give a realistic 30, 60, 90-day plan. What is this group going to do in 30 days? What is this group going to do in 60 days? And what are they going to do in 90 days? It's developed by the change team. We sit down, again, a lot of guidance, but because sometimes they want at the end of 30 days, they want all the training done. At the end of 60 days, they want to implement briefs, huddles, debriefs, closed-loop communication, and CUS. And by 90 days, we want the culture to change. Well, we all know that's not realistic, right? So sometimes the 30-day plan is just sit down with leadership and say, here's kind of what we're thinking, ultimately developing our destination postcard, our problem statement, and working from there. So they develop the 30, 60, 90 plan. Again, we're going to say ownership about 1,000 times during this webinar. They own the process. Remember, ownership is more like it's coming from them versus, hey, I have this really good idea and I want you to buy into it. Feels a little top down. This 30, 60, 90-day plan keeps the team focused without overwhelming them. So it has to be realistic. Again, it might just be, in the 30-day plan, we're going to review the team perception questionnaire, maybe kind of customize it slightly to meet our needs for this area that we're working with. You need to integrate TeamSTEPPS into what you're already doing. So if you're looking at, you have a committee that's a CUSP, Comprehensive Unit Safety Program, Comprehensive Base Unit Safety Program. How do we get TeamSTEPPS as part of that team that's already working on CUSP? And then remember, every area is different. It's not a one-size-fits-all thing. You have to consider competing priorities, and that will affect your 30, 60, 90-day plan based on what's going on there. So when we talk about shrinking the change, we really focus on these tools, and you've probably seen this slide before. This is something we really embraced quite a few years ago now. But we like to look at the tools as 100, 200, and 300 level skills, just like when you went to college, you took the 100 level skill course first and moved on. Those first 100 level skills, those first 5 are all individual skills. And you can get those going pretty quickly. And, you know, lots of times what we'll hear from groups is, yeah, we're really good at doing that at codes or emergency medications, you know, especially that closed loop communication stuff. So we're really good at it most of the time. Well, those are the kind of tools that most of the time is not okay. It has to be 100% of the time. So we push that. How do we get this rolled out there? That's what we would call low-hanging fruit, closed loop communication. You don't have to have a 8-hour TeamSTEPPS training to make this happen. SBAR, again, something that's an individual tool. And, you know, if somebody comes up to me and starts rambling on something, I can say, hey, can you hold off a second? What's the situation now? What's the background related to that situation? They may not even know I'm doing TeamSTEPPS. I'm just pulling it out of them. So that's 100. 200 requires more of the team, although briefs do too on the 100 ones. It requires a lot more of the team involvement. And then 300 level skills, those are really get into culture change tools. So as people are wanting to develop their implementation plan on that 30, 60, 90-day plan, what tools are they going to focus on and how are they going to move forward? We have some certain guidelines that you can't go right to CUS without having some sort of culture change going on. And so if you really want to introduce CUS up front, you have to do briefs. In our system, we say you have to do briefs too. Because everybody on this webinar, I'm sure, has some sort of video or sign from the CEO of your system or that says, you know, we want everybody to speak up in cases of patient safety, which is great. But that doesn't necessarily change culture. It has to be coming from the people that you're working with every day. And so in the morning brief in the OR, Harborview Medical Center, whoever's leading that brief, well, it's always the surgeon leading the brief. They will say, anybody have any concerns or questions at the end of the brief, or sometime during that brief they'll ask that question. That starts to open up the lines of communication and gets people, it makes people feel more empowered to speak up. So what does this look like? As Farrah said at the beginning, down in the bottom left there, we've given you our blank template of our 30, 60, 90-day plan, but I've also thrown an example of what one looks like in there that you're welcome to download and take a look at. But our 30, 60, 90-day plan is updated each month at our change team meetings. So we sit there, we review our 30, 60, 90-day plan. Did we meet that 30-day plan? If so, okay, now our 60-day plan is 30 days, and then we add for the 90-day plan we put on there. And this changes, every single group we work with is something different. We like to start with 1 to 2 tools. That's getting back to shrink the change. And really look for that low-hanging fruit. Where can you get quick successes? Briefs, huddles, closed-loop communication, SBAR. You can get quick successes with those. Now you have your bright spots. You're talking about that. Wow, this is really working, and we can, one group we're working with now, what they're doing is every 30 days, they're really pushing forward up one more tool. You identify next steps and who is responsible, because we all know if we say, oh, everybody's responsible, then nobody will do it. So how do we make sure it gets done? And allow for flexibility. You might get to the end of this 30-day plan, and you're in this meeting, you go, yeah, we didn't get there. That's okay. Let's just move it forward. There's the Confucius saying, it doesn't matter how slow you go as long as you don't stop, right? And so we try to push for that too and make people feel comfortable with that. So here's an example of the 30, 60, 90-day plan of one of our groups. This happens to be that Harborview OR group that they developed, and this was their very first one. They called their change team the oversight committee. That's fine. You can call it whatever you want. They set up regular meetings. This is their 30-day plan. They actually wanted to get everybody on the change team to read the books, so they had an administrator that was willing to buy these books for the change team and started booking trainings early on. And that's a key. In most institutions, the hardest thing to do is figure out staffing so you can get the trainings going and getting a room for the trainings. So in this group here, we did the training over about 4 months. It was huge. And, you know, you just get groups as you can. You get groups of anywhere from 12 to 30 attending. And we don't do 8-hour trainings for people. We tend to do, our goal is to get 4 hours training for everybody, all staff, all providers. But in our system, we're more likely to get 90 minutes to 2 hours. So you have to make sure you can drive those messages home very quick. Their 60-day plan was to present to the surgical council what they were thinking, identify possible metrics, administer the team perception questionnaire, provide switch to the committee, set dates for training, and identify potential pilot teams for briefs, and develop brief template. Now, if you look at 30-day and 60, there's nothing overwhelming there. It's just, there's quite a few things, but nothing that's going to tax people too much. And then in 90 days, they started the brief pilot. They had 5 surgeons agree to do that. They also were reviewing the TPQ results and found out, yes, the briefs would make a difference, and revised template based on pilot feedback. So they developed a template, they did a pilot, they revised the template based on that. And then down below, it just shows who was responsible for each one of those. And the nurse manager of that unit, she did a lot of the work as far as the minutes for that meeting and stuff and following up. But another group we're working with, it's somebody else, so it doesn't have to be the nurse manager. Sometimes it's a frontline staff person. The key is just don't make it too hard for them and too overwhelming. Another one we have here is another group. This is a women and children's health group that we're working with. And you can see this is what they do at their 30, 90, 60, 90-day plans at their meetings once a month, is they just kind of update that plan and they keep moving out from there. So continue to update the TeamSTEPPS. I'm in the 90-day section here. Continue with TeamSTEPPS highlights. Keep looking at that, and we'll be meeting again next week, and they'll update that again for the next 30, 60, 90-day plans. This group has already done all their training. They picked 1 month. They're master trainers in the group, did most of their training with assistance from us, but not a whole lot from our side. They did the training. They did 4 hours. They actually got 2 hours worth of training, and were able to do it in a 1-month period, 26 different trainings to get everybody in this fairly large women and children's health division at one of our hospitals. So as we move forward with that, we keep coming back to that, and we try to address resistance as we go. Like I said, sometimes it's easier not to address resistance and just ignore it, but what happens is that gets you in trouble. So with that, here's the 2 things we talked about as far as references. I'd really encourage you to look at Liberating Structures. It gives you, we use this in all of our courses. I know somebody in one of the pre-questions was asking about how do you incorporate activities into your trainings, and in our 90-minute, our 60-minute, our 2-hour, 4-hour, no matter what our trainings are, we put in there some sort of activities, whether it's our team training, tower exercise, a lot of liberating structures. You can't just give somebody PowerPoint for 2 hours and expect them to retain anything. There has to be something that drives the message home. So with that, we'll turn it back to Chris.
Well, there's a question that you can answer about the TPQ.
Could you read that for me?
Will you please expand on the team perception questionnaire?
So on the team perception questionnaire, you can find this in the TeamSTEPPS curriculum. So if you go to the AHA website, go to resources, it'll take you to where the TeamSTEPPS curriculum is on AHRQ, the Agency of Healthcare Research and Quality. And under there, there's some tools in there. And I can't remember if it's under measurement tools, but it's definitely in there. There's surveys. There's a team attitudes questionnaire, which we don't use, the team perception questionnaire, which we use 100% of the time in every group we work with. It gives us baseline data. We do that early on with every group we work with, and then we do post anywhere from 6 months to 9 months after the training occurs to see if we've moved the needle at all, because we want to see that we're actually making a difference. And pretty much, in fact, one of our groups will be presenting at the national conference in June in New Orleans, and she will present their team perception questionnaire pre and post and show that they made a huge difference on how people perceive questionnaires. Same thing. So we use that tool. I'd really encourage you to look at it. It's a validated tool. So if you customize it, it's no longer validated. But most of our groups, they choose to customize it versus worrying about publishing using a validated tool. So hopefully that answers that question.
Thank you, Ross and Sarah and Megan, for the great presentation. I'm sure everybody really appreciated it. So some questions, things that have kind of percolated up through the chat box, and then maybe some questions that were submitted ahead of time that we didn't get to. Something that wasn't really a question, but that came up was somebody said, a great tool to encourage people to use TeamSTEPPS or to communicate better as a team is looking at, the really staggering numbers that are out there for, medical errors and how they connect into communication and teamwork failures. And I know that we all agree that that's a huge thing. That's that burning platform that everybody can really utilize in their messaging. But can you talk a little bit about the importance of really finding local stories too? Like, it's one thing to say, the world's on fire, but let's look locally at something, how that's important to really inspire people.
Yeah, and when we do any of our training, our master trainer courses, when people outside of our system come here, we actually show them local. We have a really significant error that occurred here that was devastating in our system, and we share that in our system. And when we do our master trainer courses, we share that with people too. But we also really encourage people to go back and find those stories within your own health system. Because Chris, that just hits the nail on the head. People go, well, yeah, that, and it goes back to a comment earlier. Well, everybody else needs to change, but I'm good, right? We think those errors happen elsewhere, and so when you start bringing them, local, bring them back home. That wow, this happened in our system. That's where it really drives home the message. And you're right, the Journal of Patient Safety article and the IOM report and the BMJ report, those are great. And we spend every training we do, we talk about the why. We don't just jump into business team steps and the tools. We talk about the why. We bring home our local story that I guarantee you there's nobody in the room that can argue about that's a devastating story. And simple communication would have changed that entire outcome of a child. And so that's what you have to do. You don't want to be negative Nelly, but you do have to, and that's where people start feeling find the feeling with that switch model. They call it motivating the elephant and switch, but that's where people go, okay, that affects me directly. That is something that could happen. If it happened on 6 East, then it can happen on 8 East too, right on our floor, or it can happen in the clinic. And so an example we used was not even an inpatient situation, it was an outpatient situation. So,
yeah, I think another thing that I've heard you all say before, in addition to this too, is, making sure that you take data and personalize it as well. So if you're working on a falls program, for example, talking to frontline staff and saying this many falls per patient day, oh, okay, that's a number, but being able to say, do you remember Mrs. Jones? She was the nice woman with the, cute grandbaby. Well, she fell the other day, and now, there's quite the adverse event because of it. So it's making those connections too, past the numbers, right?
Yeah, exactly. And, the example I usually use is I was the patient safety officer, and I used to have to report out. We had, 4 falls per 1,000 patient days, and I didn't even really understand that number. But and frontline staff, that doesn't mean anything, so it's exactly what Chris said. Hey, Chris, can I address, there's a question up there from Julie Rose about physician and other providers to attend the training. So that is a big thing, and we run into that a lot, and especially when we teach to people outside of our system. But we still have hospitals in our system. One of our hospitals in our system, they're still not UW employees, so most of the physicians are private practice. And the key is we spend a lot of energy early on going, okay, we got to get these guys, we got to get these guys, we got to get these guys, versus, and Farrah kind of touched on this on the response to Julian there, versus finding those docs, providers, ARNPs, certified midwives, whatever it is, that want to do this, because I guarantee you there is not a practice out there that there's not at least one or two that are willing to do it. And you tap into those one or two. And then, yeah, there's a thing up there from Rachel Gardner that says cheerleader. Those are the ones that are going to do it for you. Because you can go in there and talk to them until you're blue in the face. So it has to come from one of their peers. And every single one of those groups, well, I shouldn't say every single one, but most of them, there's going to be a few in every practice that says, yeah, this is good stuff. And, you know, again, from our good friend in Tulane, Kevin Crane, he has a saying, culture change happens one retirement at a time. Yeah, you know, that's where we're going, because the younger group coming in, they're more on board with this.
Thanks, Ross. You know, earlier on there was a question about, you know, do you feel like, you know, this could be taught online or you know, some sort of, you know, remote education? I think the answer from the UW team was, you know, yeah, it can, but you need to also have time to practice the tools. And I just think that I wanted, you know, to kind of bring that up here, you know, verbally and re-stress that. Like, none of these tools are rocket science. You know, you could send somebody something to read or see what SBAR is or what a brief is. But the importance of taking the time, like you were saying, Ross, even in a you know, a staff meeting or just, you know, in some sort of, you know, daily rounding to you know, practice those tools and not just say, here, use them. That's just really important. All right.
Oh, I'm on mute. I'm sorry. Sorry, Chris.
That's okay.
You're on mute.
Okay.
Just to echo that a little bit, we've had some, it's not a change that happens overnight. We've had some groups that we've worked with that we've been working with them for 4 years, and it's a ongoing series of 90-minute trainings just to get the fundamentals out there. And you start to see kind of this slow snowballing of effect or implementation, but it takes time. And so not being discouraged by the fact that just because I can't get everybody in the room at one time, this is impossible. It's taking what you can, building on those kind of smaller, bright, getting a few people at a time.
Exactly. Thank you. I think the last question I have, something you touched on, but it was something that really struck me from one of the pre-work questions, or one of the pre-questions that people submitted, was, you know, we talk about empowering frontline staff, and I think that asking people to take ownership of something, you know, that's empowering them to do that, right? It's, you're taking ownership of this process. We're going to do TeamSTEPPS. It's up to you to figure out what we're doing. How are you going to own it? But what do we do in situations where, you know, frontline staff, yeah, they're told to take ownership, but they maybe psychologically don't feel safe or don't feel like they can take that ownership? Have you had any experience of trying to get past that blockage?
Yeah, we have, and part of that is sometimes leadership doesn't want to give up that, right? So what we find is we spend time with leadership convincing them that this has to happen this way, because we've seen it not go that way and we haven't had good success with it. We've seen it in our system. We've seen it with groups who we work with outside of our system, where they said, no, we're going to do this, this, and this. And we'll say, well, what does the frontline staff want? And they go, well, this is what we're going to do. And then it becomes a top-down thing along with the other top-down things that you have to do. And so it's not successful. So what we do with those groups is we spend a lot of time shrinking that change, not make it overwhelming, because if you're already taking care of patients and you're a provider or you're a nurse or you're a pharmacist or you're a social worker or housekeeper, whatever, you have to make sure it's something they can do without adding a bunch of time to their day, or they're stressed out because they're missing nobody's taking care of their patient or whatever. And so you get that early success with these groups, and then that's where they start flowing. And an example that Megan just told you about, this group, that's actually been 5 years we've been working with them, their leadership hardly shows up to the meetings anymore because this frontline staff has taken this group and they've run forward and they've had great success. But it took a while. That's what took so long, is to convince the frontline staff that this is your project. You guys are doing this. And so you just keep pushing it forward. Most of it's spending time with the leadership, making sure they convince the frontline staff that they're not going to run the show. And sometimes that's harder. It's easier said than done, really. But that's where we've got our success. I don't know if you guys have anything to add to that.
No.
Thanks. Well, thank you all. Really appreciate the great presentation and also the time you spent answering questions. I know that if anybody has any further questions, stay in touch with us at AHA Team Training and we can get those answered for you. The materials on the screen right now for how to get in touch with us. Download that little file there there's some instructions. There's 2 files there that are instructions for how to get your CE credit. We apologize for the wrong number for a second there. First time we're offering this, and so we're learning how to do it. It seems kind of unique to be able to do this via text message, so hopefully it works for everybody, but please contact us within the next 24 hours if you're having any struggles, as it will only be active for that time. We'd also love for you to do the evaluation that comes out to you as well. That is something that we really do take to heart. We have a monthly meeting where we go over evaluation numbers that have come in from our courses and our webinars and everything. So this is something we really do. So please do the evaluation if you have a chance. With that, I'd like to say thanks to everybody and enjoy the rest of your day.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.